Perfect timing, thank you. So we have about 10 minutes now, if we choose to, for any questions and comments just to Lucy. And then we will move into our panel session, including the other speakers. So does anybody have any comments, questions they'd like to make to Lucy? I can see a hand in the middle, please.
Hello, I just wanted to check with the team formulation. If the service user is able to do so, would they normally be involved in that?
They would be very much involved, I hope, in the sense that their understanding of their difficulties, which I hope they would work out with a professional they know and trust, would feed into our formulation. Our formulation would be checked with them in a kind of recursive process, if you like, in that sense, yeah. I mean, this is different people do it in different ways, and the older adults, so as I described to you, they often have the client and the family in the room, and I think there are pros and cons to that. And one of the disadvantages of that, I think, is that from the service user point of view, your formulation may include a lot of quite personal stuff that perhaps they don't want to discuss in detail with a whole group of people. From a staff point of view, inevitably there are often kind of quite powerful feelings of, frustration, stuckness and so on, which it isn't necessarily useful or helpful for the service user to feel, and yet they need to be expressed and understood and worked through. So that's one reason for keeping those processes to some extent separate, but making sure they feed into each other. But there's no single way of doing it. But that's the way that I personally found it works best. Sorry.
I just wanted to ask that, as well as campaigning for use of formulation, would you be able to campaign for the use or finding new terminology for service user? Because I think that's such a disempowering term. We're all people, I'm a person, whether I use a service or not, and I just think there might be a better way of bringing the person back into that terminology.
Fair point. The trouble is there's no completely satisfactory term, is there? So some people object strongly and rightly be called patients, some people identify as survivors, some people don't. So it's quite a tricky one, but the simplest answer is to call people people, isn't it? Yeah. So somebody else has wanted to ask?
No, sorry.
I think you're referring to open dialogue, is that right? Yeah, I think open dialogue's a fantastic approach, and I think that's kind of what I meant by if you're setting up a system from scratch, I think we might do it a bit differently, and they do it differently, don't they? Right from first contact, it's about dialogue and discussions, and I think those are very much the same principles, aren't they? It's about dialogue, communication, getting people in the same room. I'd love to see that approach spreading more widely. Yeah, I think that's a compatible approach, although not an identical approach.
Okay, if we have no further questions specifically for Lucy, then I would suggest we move into our panel session. If I could ask Sami and Euan to join us at the front. Eleanor, I'm afraid, has to go for her train now. And we'll see if there are other questions that people would like to put to one of the other panel members or to the group as a whole to see ideas bouncing around. Okay, then.
No questions, okay, let's go.
And I'd just like to start, if I may, by just saying how interesting it has been to have a range of speakers. And I think I might open direct this to Euan first of all, because Euan, you were in the rather unfortunate position of speaking first and speaking very much from the angle of your particular service, which I know attempts to use the same sort of approach that others have talked about. I don't know if there's anything you would like to say, having heard the other speakers, in addition to what you had said at the beginning.
Yeah, I think you're quite correct in that assumption, actually. It was relatively difficult to go first in the context of what we were discussing, in a way. I think there's a level of concordance between what the three speakers who followed me were saying and the way we're actually trying to develop services in Wales, to an extent. Obviously, other areas, I suppose in the climate that we work in, we don't have the ability to offer something that maybe Sami can offer with his skills and experience and expertise, because it's difficult to attract that sort of expertise to Wales, so we muddle along with what we can actually do. But I certainly do think that our aspirations are to provide something similar, not as radical, I would say, but certainly similar. Yeah, I think the provision of the therapies we provide, which to an extent may or may not have an evidence base for what we're actually doing, is great. I don't think we have a reliance on medication in early intervention services per se. We do in other services, but we're certainly trying to aspire to the goals of recovery and to do everything inclusively. I'm also quite fond of the open dialogue approach as well, and the core of our services are the people that we're working with. So yeah, I think maybe if I'd gone second or third, it might have been slightly easier to say what I was trying to say. But as I said, my slides are there, so just please, feel free to contact me, and I'm more than happy to chat. One of my aims, and I know the aims of Les and Barbara, is that each of the health boards in Wales actually develop an early intervention in psychosis service, because I do believe that it works, and I do believe it's a service that people should have access to. I mean, I'm on my 30th year anniversary of training now, and when I trained, we didn't have anything whatsoever like this, and I can see a huge difference from what we had to what we've got now. But again, listening to others and listening to Eleanor, there's also a big difference there as well, really. So I think we're moving forward. We might not be as far forward as some people, and we might have a slightly different approach, but I think we are trying to do something that is useful for people, and that's really why I do it. So yeah, maybe if I'd gone second or third. That's a good point, actually, but there we are.
Thanks, Euan. Any questions from the floor? Any comments on common themes, differences? There's some hands at the back.
Hi, my name's Ian Nesbitt. I work as a psychiatrist on Merseyside, and I've just got a question. I've got a feeling from the theme of today, really, that there's a bit of a tendency, really, to demonise psychiatry to a certain extent, which is fair enough, because we've all got thick skins and we can cope with it. For patients, tell us they have off. A bit of academic disagreement is no bad thing. However, I have worked in an early intervention service myself, and I think we run the risk of just seeing one solution as being the answer, when in actual fact it's much more of a jigsaw puzzle of an approach. There is a role for psychiatry as much as there's a role for psychology, but I think we have to realise that at certain points in a crisis, for example, there's much more of a role for medics, and at other times when people are more stable, then psychology plays much more of a role. I'm thinking of a 19-year-old lad who's admitted to the ward. Telling him he's got complex unresolved trauma probably isn't going to be as helpful at that stage as maybe 10 milligrams of olanzapine is going to be. So I think that we have to take a more balanced approach, and I'm just wondering what the panel think would be a balanced makeup of an early intervention team, because the team that I've worked in has different roles for different people: clinical psychologists, OTs, CPNs and doctors, but they all have different roles at different times and different levels of intensity at different times. So I'm just wondering what you see as being the makeup of an early intervention team here in Wales.
I mean, I run one in a way, so the makeup of my team is similar to a core community mental health service. We've got community psychiatric nurses, we've got some embedded psychologists or psychotherapists, we've got one OT. We haven't got an art therapist, even though theoretically, if you read the guidance, we should have. We've only got one for the health board. It mirrors other services, but I also think we have to have a much broader understanding of the third sector and the other services out there that aren't statutory or the non-statutory services and have quite a good link up with them, really. I'm also keen that we have quite a strong link up with educational services in schools and colleges and things. I do agree that there are people have different roles at different times, but I also think if we can intervene as early as we can intervene, then maybe some of the crisis stuff that we're talking about, we may be able to divert people away from that, and then we may not have to have a medical crisis in the context of what you mentioned. But again, sometimes that is unavoidable, and also it goes with the territory. But I think it should mirror what good practice is. In Wales, we have quite a lack of psychiatrists, really. We've got one session of a psychiatrist to cover the whole of the early intervention service. Then we use the locality psychiatrists, so there's not a lot of those people on board. So we would have a tendency to probably offer more psychologically focused than medically focused stuff. And certainly we do try and shy away of people in primary care from medicine as such, unless it's, the last thing we can offer, really. Yeah. Don't know what other people think.
I'm a psychiatrist. I don't work in an early intervention team, so I can't comment on that, although I work in a trust, obviously, that does have them. I work as a community child and adolescent psychiatrist, but I've also been an inpatient child and adolescent psychiatrist. And yes, as psychiatrists, we do have to wear thick skins. But I think the challenge for us is both in running services, but also particularly for us as psychiatrists. It's not so much about, because I think most psychiatrists are actually pragmatists, We work with what we have. And the interesting thing for me is speaking to lots of psychiatrists and being part of a community of psychiatrists is actually a lot of the ideas that I say are not that far away from what actually happens in reality rather than in theory. In reality, we don't think that diagnostically. We tend to try and respond pragmatically. And I would agree with you. There is certainly a place for medication, and there are times where certain types of formulations and explanations might be just wide of the mark for responding in a way that might be helpful to that particular situation. And I think that's the type of uncertainty that we have to always be prepared to deal with. One thing that I might see as slightly differently for us as psychiatrists is I think we've had the misfortune of being boxed into a corner by partly by the institutions we work with, but also partly by getting too insecure about our identity as doctors. So I tend not to see the role of a psychiatrist in the way of being the person responsible for diagnosing and for using medication. That's certainly part of the things that are asked of me. So a lot of the work that I do involves from the start thinking about what might go alongside. So your young lad who's presenting in a crisis, who might benefit, and I would always use that word rather than need, who might benefit from some period of medication that hopefully they will be able to agree to. It is not, what's the word I'm looking for? It does not mean that you can't start the work on formulating a more meaningful, a more encompassing way of thinking about what might be going on from the start. So I usually take the position when people present to me with psychotic symptoms, for me it's trauma until proven otherwise. I might not find out the full story, but that doesn't mean that there aren't other things that I can do. Sometimes that leads to medication. When I use medication, it's usually with the idea that the model that I would be selling will be the model that people like Joanna Moncrief write about, which is that medications do not cure biochemical abnormalities. At least if they do, we haven't been able to find them. But it's most likely that they work by creating biochemical abnormalities that might coincidentally be helpful. So antipsychotics work by essentially dampening down the brain's activity. And if you've got voices telling you to kill yourself, that might be quite helpful at that moment in time. In fact, it might be life-saving. However, the process of making sense can be included into that. And we have to be very careful about how we then formulate those, because if we start formulating these in terms of the medical model illnesses, we might be inadvertently passing responsibility for getting better away from empowering that person to make sense of their experience and more towards the role of the expert. So I have certainly some sympathy with what you're saying and some understanding of your position, but I think the two positions are not antithetical, and I think we have psychiatrists, if they want to ensure their future as a profession, in my opinion, need to get a lot more involved in these wider meaning-making processes, which we can be just as good at. In fact, we've got quite a good position, given that at the moment we are probably the only profession that could be tasked with looking at the whole thing. Yeah?
Well, I think the responses have been made. I just want to emphasise that this really is about ways of thinking. I think it gets into a very unhelpful debate when we start characterising it in terms of all sorts of things. I mean, the media picked up the kind of diagnosis controversy very much in terms of psychologists versus psychiatrists, which I can assure you from the point of view of the DCP is not how we were seeing it. It is about ways of thinking. And so the particular professions in a team is much less important than all being on board with a shared model and all being willing to think psychologically. And whether or not you use medication is much less important than thinking about why you're using it and what the meanings are. And, the evidence is that this can be helpful. It's not about treating illnesses.
I'd just like to take issue with something that, Sami, you just said, that it is trauma until proven otherwise. I think that's quite a dangerous standpoint to take. I'm a really, really junior doctor, currently working in psychiatry, but I haven't yet entered specialist training and don't know if I will. You're all kind of slating psychiatrists here. I might go into anaesthetics, but I do have a degree in psychology, and so I'm kind of got a foot in both camps. But I just think that's really dodgy. I just think, especially if you take Lucy's one-size-fits-all formulation of a service user X who, will get into the habit of swapping symptoms. If they feel from you, transference, whatever, that, you think this is trauma underlying all of this, then, they may provide you with the answer that you want to hear. And I just think, what about the 15% that don't have a history or whatever? I mean, you might say, don't have a proven history. I don't know, I just think it scares me a little bit that you say that.
I did say until proven otherwise, which means that I'm assuming that not everybody will have trauma. But I'm also assuming that that's a good starting point if we are ending up looking at possible causal. But I have to say, a lot of my work involves thinking about what might make a difference. And that somehow can be more important than thinking about what's gone before. I'll give you an idea about that. For example, a number of people from the more brief and systemic therapy movement, and this goes back to developments that happened in the sort of 60s and 70s in the family therapy field, began to think about the problems that we come up with, we encounter in our work in a slightly different way. They began to think about, well, up until now, most of the services and most of our theories have been based on assumptions about causality that link things in the past or link things in neurobiochemistry or whatever. And they came up with this idea, well, what if the problems are related to how we react to the problems that happen in our lives? And that what happens is that most of us react when we have problems in our lives in certain ways. And then we carry on trying to solve our problems in the certain ways we're used to, or we've learned to do that. And what about if we come across a problem that way of trying to solve that problem doesn't help that problem, actually makes it worse. So this is the concept that actually it's the problem that causes the problem, and we enter into vicious cycles. So for example, somebody who hears voices, their response might be to try and get rid of them, and that might be a very rational response, but actually trying to get rid of them doesn't work, and so they get into this battle. And so one way, if you start to think of that way about how you might work, is, well, let's find different ways out of this vicious cycle. So, for example, to come back to that voice hearing situation, it might be, well, let's try and work on, instead of trying to get rid of the voices, let's work on trying to change your relationship with the voices. Because at the moment it seems that they have a lot of power, and getting rid of them as a strategy. So a lot of these kind of brief and systemic strategies, which are a lot more playful, more creative, and think in different ways. So the thing about, you know, trauma, as I said, it's assumption until proven otherwise. So it's just a useful idea, and it does seem to come out, in my experience, in many people who experience psychotic symptoms, there is often something there that you can work on. But that is not the only one, and I wouldn't want that to be
Does that
to be
deny-
a new dictatorship of, you know, this is the reason, yeah.
Does that deny that, you know, that there could be any sort of organic cause of voices? I mean, what about in your elderly population who go, you know, start hearing voices and it's not connected? It's, you know, it's a dementia, it's a brain,
Sure.
You know.
Sure.
It's,
Sure, you can get that from, you know...
They don't have to have meaning.
You can get that from...
It'd be nice if they did, maybe, because we could help them or whatever, but...
Yeah, absolutely. You can get that from amphetamine abuse, for example,
Exactly.
which would be... you can get that in a number of physical, you know, delirium states, various organic states. Absolutely. Yeah.
Thank you.
Should I add to that? I mean, just to, I think it's important to reinforce this point as well, because I mean, I don't think any of us have said everyone who breaks down in a way we call psychosis has suffered from trauma. You know, that's clearly not true and not a helpful thing to think about. And clearly there are organic causes which can cause what looks like, you know, other types of presentation. Those need to be excluded. And we're not talking about trauma in a narrow sense. I think that's a slightly confusing aspect of the literature, that usually what they mean by trauma is one of a number of possible things, usually a combination. Could be the kind of classic sexual abuse, could be emotional neglect, could be physical abuse, could be bullying, could be being on witnessing or being on the receiving end of domestic violence. So there can be a range of traumas. Could be war, could be combat, could be all sorts of things, natural disasters and so on. So it's a kind of, in some ways, an unhelpfully precise, loose term. But I guess another way of looking at it is that unless proved otherwise, unless there are organic causes, you know, people break down for reasons. You know, I can't, unless there has been an organic cause identified, which occasionally there has been with people I've worked with, I can hardly think of anyone, in fact I'm not sure if I can think of anyone, who didn't, upon really close, you know, getting to know them, talking through things with them, turn out to have, you know, understandable reasons for feeling the way they did. You know, perhaps that's the central message. And sure, we don't want to be kind of telling people they've got traumas, overstating it if they haven't, but equally we don't want to be overlooking trauma that is staring us in the face. And I think if Eleanor was here, what she might be saying is that it was jumping out of her notes all over the place. Do you know what I mean? She was having voices who were talking about, I don't think she'd mind me saying that, talking about doing abusive things to her. This was somehow totally ignored for years. This is much more typical in psychiatric services. We are far more in danger of overlooking trauma that does happen than than inventing trauma that doesn't.
Yeah, I mean, I'd probably, I suppose in my practice, focus on stress, really, stress and vulnerability, and the fact that stress is quite difficult for people to deal with and cope with if they've got these sorts of problems, and often when the situation becomes stressful, they have a tendency to become poorly. I mean, everyone reacts poorly to stress, and I think there's been quite a decent model developed recently by a chappie called Anthony Morrison, who's a professor of psychology up in Manchester, and he's developed quite a nice stress-related model that tries to actually explain why people have hallucinations or delusions. And he used a model that was developed by a chappie called Clark back in the 80s, looking at why people have panic attacks. And the idea was, he was basically trying to say, well, it's a similar sort of thing, really, but instead of having panic, you hear a voice or you have a strange thought. So again, I may not focus on the trauma and the related stuff. I might just actually look at the here and now, what's actually happening for the person, and try and deal with that from a stress and a difficulty perspective, really. And if when you're developing your formulation and you're developing your therapeutic relationship, the other stuff comes up, then you might work on it. But I certainly wouldn't focus in and say, well, actually, 13-year-old, hearing voices, bit of trauma there, that's what I'm going to look at. And I don't think anyone here is saying that, but they are saying that there is a correlation. So I think the stress that the person's suffering from, if you think about the bipolar, it's the same. You've got the stress diasis model. People become stressed, they might become poorly. Yeah, I was quite stressed this morning when I was talking to you all, really, and I was somewhat more nervous than I normally am, because there's lots of you here, and again, the focus of the day is an interesting day. So people just do become stressed, and I do quite a lot of teaching. And one of the examples I use when I'm teaching my people, predominantly see cognitive behaviour therapy, is that if the teacher teaching you suddenly behaves in an unexpected way, it's because they've spotted someone in the class doing something. And my example is there's someone looking out the window, there's 19 people looking at me and listening to what I'm saying. There's one person looking out the window. I look at that person, it wakes up a thought in my head that's telling me that I'm a really bad teacher, so therefore I become stressed and I can't handle it and I go to pieces. So I think stress is quite important when we're thinking about these things, really, and sometimes we don't actually think about the stress that people are under. And I think we should do. And having those sorts of problems in the past is stressful. You might not be thinking about that when you're actually becoming hallucinated or deluded or whatever, but that might be something in the background, making it bad. But you need to focus on what's actually going there now for the person and start working on them with that, really, if that makes any sense. Sorry, I didn't mean to speak that long, but here we are.
Sorry about the feedback. I wanted to make exactly that point, actually, following on that I was hoping you might make the point that trauma doesn't have to be a big trauma. It doesn't have to be sexual abuse. It can be lots of small things build up over time, being ignored, not having a good support network, having a family where problems don't get talked about. You're supposed to keep a stiff upper lip. And I also wanted to raise the point that there's some interesting work on sensitivity. Eleanor has done some work on highly sensitive people, and there are people in the population who have more sensitive nervous systems and are more easily affected by stress. And that's not wrong, it's just different. And I just wanted to make that point as well, that trauma doesn't have to be in capital letters. It can be quite low level and still have a profound effect later.
Yeah, it's interesting, because that's one of the ways that I go about thinking about when I'm working with young people and families. And it has some similarity with what you were saying, Euan. I have this generic model which I see as a fairly normalising model, which I say to people, we all get stressed, and I just talk about stress in a very everyday sense of feeling emotionally overwhelmed by whatever it is that's going on. And different people are wired up differently, so react to that feeling overwhelmed in a different way. Some people get headaches, some people can't stop talking, some people get very socially withdrawn, some people feel sick and dizzy, some people have nosebleeds, and some people hear voices, and some people have unusual thoughts. Some people get very paranoid. So I use that as a very normalizing way of the types of different presentations that we have. And most people seem to relate to that. That seems a fairly easy, ordinary, everyday model way of, rather than talking in more language like trauma and so on, actually talking about stress and feeling overwhelmed is something that a lot of people can connect with.
I'd like to ask one question, if I may, from the chair. Just thinking about everything that's been said about, in some ways, the initial contact with somebody who comes to you, and using a formulation, maybe not so much a diagnosis. What I'm just a bit concerned about is, I know recently here in Wales we had a review of psychological therapies, which showed that actually there was very limited access to psychological therapies, unfortunately, particularly for inpatients, it seemed to me, very long waiting lists for those who need it. And so it's a question more broadly as to, once you have encountered somebody in need, who's experiencing various different things, how they are then helped, given that there does appear to be a shortage of well-trained people in the NHS in Wales to help, and whether you think there's any particular form of psychological therapy that is the most helpful, or whether you...
I'm going to challenge you on that. I don't think there is a shortage of psychological therapies anywhere in the mental health services. We're just not using them. We're thinking that, every encounter that I have is psychotherapy. If the object of the interactions that I'm having is something to do with changing or affecting or influeing somebody's mental state, whether I'm using drugs, whether I'm using a conversation, whether I'm talking about strategies, whether it's just listening, if that is the objective of that interaction, it is psychotherapy. Now, whether we like it or not, we're all involved in psychotherapy. It's this ludicrous idea that there is a little group of people here that run psychotherapy services, and that those of us who are involved in frontline work have to get out of that mindset of thinking that it isn't our job to start engaging and thinking with people psychotherapeutically. If we did that, most of the work that we would do would not be long-term. It doesn't need to be long-term. And if we had and I think we've demonstrated that in some of the work that we've done, if you had a way of reviewing the outcomes of the various things that you have on offer and adjusting what you do based on what happens in terms of the outcomes and making it everybody's business, then you can make these changes without increasing, that's what I meant earlier on. This is not just an issue of funding, this is not just an issue of staffing, it's an issue of how we think about what our task is in services.
Can I add to that? I mean, I do agree with that. You know, we're never going to have the infinite number of therapists that some people might think we need. We have to, but I think the message of a trauma-informed model, as I understand it, is that we are all dealing essentially with the same kind of difficulties, and we all need to be skilled in doing that, and we all need to have those as our core skills. So the three-stage trauma model, which Eleanor briefly outlined, starts with the kind of skills I think we all need to have and should have, which is dealing with disclosure, asking about disclosure, making sure we know what's going on, education about the effects of, you know, in some cases, trauma on the mind, on the body, on the kind of explanations of the difficult experiences you may be having, and stabilisation, how to learn to cope. Eleanor talked about it in terms of voices, but more generally, how to get a better handle on the distressing experiences that you're having. Now that sets the stage for, if for some people, not everyone, more intense, in-depth psychological work, which may be the province of, you know, particularly trained therapists. We should and could all be doing the first stuff, which is important therapeutic work. You know, that's the kind of shift of thinking we need to make, isn't it? We're essentially doing the same kind of work, whatever our professional background.
Yeah. I mean, I just like to add in a way, what we've attempted to do at my health board is that we're endeavouring to train all staff to offer some level of psychological therapy. And recently we've worked closely with Swansea University to introduce psychological therapy training to undergraduate nurse education, which you might be shocked that it's not in there, but it's not in there. I run some of the stuff for Swansea Uni, and it's not as good as it could be. So what we've offered as a health board is that we'll train them in the underpinning ideals and ideas of psychological therapies. Once they qualify as a staff nurse, we'll then take 2 years to train them up to be a practitioner. And then we're sort of developing our own workforce of psychological therapists. It is true that the audit they did into psychological therapies in Wales came out particularly poorly, but one or two areas came out quite well, and one of them was early interventions in psychosis. They also compared Welsh services to Scottish services, and we did atrociously as well. The papers are actually, you can Google them, they are in the public domain. And I do know that the majority of staff can offer a level of psychological therapy, but if they've got to do 28,000 other things and juggle the paperwork and do all the electronic records and drive around 3 counties of Ceredigion and Pembrokeshire and Carmarthen, then it's going to be difficult for them to do psychological therapy. But as management structures and as lead clinicians, we need to be able to support them to do that and enable them to do that. Because when I talk to nurses and others, they come in, that's what they come into the job to do, which is what you're saying.
Yeah, yes.
They train to be a nurse because they want to help someone and they want to offer psychological help, but they can't do that when they qualify because the environments they go into may not be culturally able to actually provide that. So I think we're working hard at the moment to alter those services and to actually introduce that level of work. When I trained to be a nurse, I probably had more psychological training than any of the nurses who are coming out now. I've obviously done loads of other stuff since then, you know, but it's something that we need to provide, otherwise I think we're failing again. Similar sorts of ideas, but you know.
I think that interesting point. We have got time for one question in a moment, but just to say that I think that question of culture shift is so important, and giving the very able staff that we do have the confidence and the time to use the skills and have more psychologically minded services, I think is what we need to be aiming for, and maybe we can come on to that in the final informal session of the day. We have one question. Could you use the mic, please, because we're recording, if that's all right?
Yes. My own experience, both as a health professional and as a service user, is that early intervention is critical. Being treated as an individual is also critical. But there's a point at which one recovers. And how safe is it to continue those interventions in the community? When you discharge somebody, how can you help that person to create a positive peer group in the community, particularly in areas of social isolation? So how safe is it for professionals to share their skills with the community?
That's such a great question, and a really crucial one, because what can sometimes happen is that you get a professional system that becomes your social network. And if that happens, then it becomes very difficult for services to discharge you. Whereas really, you want a social network that is not also a professional network. You know, you want real people. Apart from the voluntary sector, but there are some very creative people out there who talk about community building. There's a psychologist in Shropshire who does these walking tours. They just go out for walks, you know, and have a. There's no obligation. You just go out for a walk, and it's become really, really popular. But you know, ideas like that, which are really straightforward, they're really just about, you know, creating possibilities for human connection at an ordinary level. I think that's such an important question, because I think our services have a tendency to without intending to, encourage people to become long-term patients. And this is where we could make a huge set of differences in terms of efficiency. If we saw that our jobs in a little bit more ordinary, there's a lot more ordinary things we could do that doesn't need great trainings to become elaborate interpreters of deep unconscious conflicts or whatever. And it's these ordinary things that would help people move through services and out the other end and just get on with your life. You know?
Yeah. I mean, we're sort of, wherever possible, endeavouring to keep people in primary care now, and I know there's a few representatives here from the early intervention service in the Neuron Bevan, and they're offering a clinic with the local uni now, actually run on the uni premises, which is completely and utterly removed from health. So I concur with what you're saying, and again, we're trying to develop the same now with Aberystwyth University, and we've been approached by a number of the schools in the area to actually provide a level of training for their pastoral care staff as well. So I think the impetus is, as you say, to take it outside. If you look at the models in Australia, and the one in Melbourne is completely and utterly not in mental health services. You know, they've got facilities in shopping centres, in malls, and all those sorts of areas, really. So I think once we actually, it becomes like an ivory tower in health, and people get stuck in there, and it's difficult to get out sometimes. So we need to stop that stick. We need to not, unless it's, as the psychiatrist from Merseyside mentioned there, unless it's an imperative, you want to try and keep people as far away as possible, really.
Yeah. Nothing to add to that. Wonderful, thank you. We have now reached 3:30, so I'm going to move us on. And I know we now have, actually before we do that, let's just thank our panel members. Thank you.